Before we start with the vaccine portion of the conversation, I always like to say we are still in an ongoing pandemic management. And so I would like to make some highlights or some comments related to other aspects of the pandemic response outside of vaccination. The first one is to comment on our cases and how they're moving forward. Now, fortunately, we have seen a downward trend in our numbers as well as the state level. Again, as we talked about last week, we're moving in the direction away from seeing days reported of cases over 3,000 on a state level. And less days of us being in the 400 to 600 range. And we have seen improvements in our test positivity. Yesterday, our 7-day average was below 5% for the first time in over a month and a half. And our case rate, dropped below 30 cases per 100,000, again, for the first time in at least 6 to 7 weeks. Now, one day of good numbers does not make a movement in the other direction, but it is giving us some positive signs in terms of being able to review some of the policies that are in place. Now, obviously, we want to, consistent with the approach that we've taken throughout the pandemic, we want to see continued movement in that right direction that would demonstrate sustained trends in the positive direction before making any other types of decisions or changes to any policies that we have in place. Now, I will also like to say that there are challenges within that. So yes, we are optimistic that the numbers are improving, but at the same time, we're also dealing with the presence of other variant strains of COVID that have shown to be more contagious and more easily spread throughout our communities. Now, there was a report put out yesterday, just very briefly, and I will caution we have very limited information, but we did receive a report that we had 2 Montgomery County residents who had a preliminary positive result for the South African variant strain of COVID-19. We're awaiting further information, but at this time, it is suggested that the cases were tied to travel and not community transmission. As we continue to find out more information, we will make that available to the general public. But in the efforts to be transparent, we wanted to share that information and let folks know that. There are, I think, somewhere still around the mid 200s in terms of the number of cases of the UK variant strain in the US. We've had 3 reported in Maryland, and the South African variant strain, much smaller numbers. In fact, the first case was reported in South Carolina last week, and Maryland reported the first cases over the weekend, the second state to do so. So I just want to make sure folks understand that, and the Maryland Department of Health is increasing its capability and capacity to do sequencing on those viral strains to be able to detect the presence of those variant cases. So those are our global perspectives in terms of where we stand in community transmission. We continue to test at an elevated clip that is consistent with mitigation levels. We are continuing to explore opportunities where we can increase access to point of care testing. We are working with our school system to explore how they can integrate testing for their staff and their students upon return as they look at going back to school to, again, increase opportunities for added protection and to minimize potential risk of transmission in those settings. Now, with that said, I would like to pivot to vaccine distribution, and if the moderator will allow me to share some slides, that's okay. Good, there we go. All right, so we're looking at the vaccine report. There we go. We're going to go through some numbers. I would also like to start, before we get into this, we have received a lot of questions about equity and prioritization of those zip codes who've been hit hardest. So I'd like to give you some insights for the folks at home into the world we live in. We get emails from everybody on all sides of the issue. We've discussed and we found out there's not 2 sides to an issue. There's usually 65 or 66. And we get emails and opinions from everybody exploring and expressing all those issues. And one of the issues that we've received feedback on is this notion of equity. And so on one end of the spectrum, we've been asked, well, why don't we prioritize certain places and certain locations to distribute vaccines? And how are we factoring in equity? I think one of the most poignant emails I received over the weekend was from someone who mentioned that we as a county have no problems with equity in the body bags in terms of who are dying from COVID, but we don't seem to prioritize equity when it comes to the distribution of the vaccine. I would like to personally dispel that myth that we do. And we've been very vocal about our efforts to try to integrate equity principles into vaccine distribution so that it is a fair, equitable process where everyone has fair access to the vaccine, particularly those communities, whether it's by geography and race and ethnicity and age and gender, who have been disproportionately impacted by COVID-19 in terms of the number of cases, the types of exposure that they're exposed to, as well as the number and rates of case fatalities related to COVID. So I want to underscore that. There was an article in the New York Times over the weekend, as well as one in the Washington Post. And so for the folks at home, rest assured that we have been looking at those principles from the very beginning before we even moved to increasing access for certain age groups. Now, when looking at the numbers, again, this breaks down where we stand. We are actively, the county-led vaccine sites are actively providing vaccines for those individuals on the right in 1A and 1B, prioritizing those who are over the age of 75. And when you look to our numbers on the side, you see how many, and the percentage of folks who received their first shot versus, and also including those who received their second shot. We currently stand at, we have vaccinated just shy of 7% of our total population, which is just shy of the state average of 7.1. This breaks down, again, the number of doses that we've received, the number of doses that we've administered, and then also looking at the percentage of population. Again, the state average is 7.1%, and we have vaccinated 6.5% of our total population so far. Now, we did hit a little bit of a snag yesterday with inclement weather. We did cancel and reschedule our clinics from yesterday and reschedule those individuals. Including our allocation last week, we received 37,000. Yesterday we had administered just shy of 33,000 first doses. We have 2,400 scheduled today, and so I predict and imagine that with that number, we will be close to well over 96 to 97% of our doses administered within the week. And here's a breakdown, again, in a different way, looking at the health departments in terms of how the doses have been received, as well as the percentage of those doses that have been administered. And here are the pre-registration statistics. One of the concerns that we have talked about before is that when you break this down by race and ethnicity, it certainly does not mirror the population breakdown within the county. And that's one of the strategies I know that the communications team is working on, and they have discussed with you all in previous conversations a multi-pronged approach to provide education and outreach to increase pre-registration, which we think is a barometer of ultimate uptake of the vaccine once folks are eligible and able to register for the vaccination. Again, here's just another schematic that breaks this down. This is done over a time interval that shows, as time moves forward, the volume of folks registering, as well as the percentage breakdown within respective communities by age, as well as race and ethnicity. And again, another background demographic breaking it down by race and age in terms of pre-registration. Here we go. And this again highlights the breakdown, and you can see that there is, again, it does not mirror the actual racial and ethnic breakdown of county residents in terms of percentages. Now, we also are not the only town and shop in town that is administering vaccines. We know that our health systems are also administering vaccines through their clinics. We are thankful and excited about continued partnership with all of our health systems. They have stepped up and are utilizing doses that they had left over from their initial allotments that were originally planned for healthcare workers within their systems. They have begun using those doses to help support community vaccination. And in many of those places, while the county, again, is emphasizing and prioritizing 75 and up and 1A folks, they have moved further into the prioritization groups into 1A, 1B, and 1C. This week, when looking at our allotment of doses, the health department received 5,500 doses again, which was the same number of doses we received last week. Our partners our colleagues at Suburban received 2,425 doses. Adventist received 2,175 doses. Holy Cross received 975. Kaiser received 1,100. And Mobile Med, one of our county's FQHCs, received 100 additional doses. Now, we do know that other pharmacies, retail pharmacies, will be brought online. Giant was started last week, and we know that Rite Aid and Safeway are others that will be brought online this week. We have a conversation scheduled with at least one of those this afternoon to talk about how we can potentially leverage those vaccines that they receive to provide additional coverage to educators within our county, as well as other populations that are deemed to be highly at risk and vulnerable for COVID-19 acquisition. So I want to emphasize also that one of the other controversies from the last week was related to providing vaccination for educators and teachers. And based upon the traffic of email that I've received, and I'm sure you all have received as well. Now, we have not, as a county, we have not taken a position to deprioritize any group versus the other. That couldn't be further from the truth. So again, for the folks watching at home, let me be very clear about that. We have worked with, at least in the last week, there was a partnership, an effort to support Hopkins in getting out the doses that they received from the state. They worked very closely with MCPS to provide vaccination to approximately 4,500 prioritized staff within the MCPS unit. We connected them with leadership from a number of non-public school entities. We worked, Dr. Stoddard and I actually had a town hall with leadership from non-public schools on Friday to discuss these issues. And we know that after meeting with them on yesterday, as they continue to roll out, they have expanded that opportunity to provide vaccination to educators and staff in non-public schools as well. So moving forward, they will be working closely with those leaders from those respective schools and entities to include them in their allotment of doses. Let me also emphasize, however, is that there are other points of entry in places where educators can get vaccine currently. In the other clinics that I mentioned, Holy Cross, Adventist, and I believe through Kaiser. And again, we are working behind the scenes to create even more partnerships so that we can increase points of entry for those individuals. I would like to close, and again, here is a section of who we're currently vaccinating right now. Again, it's 75 and older, and those in the 1A category. But I would like to close with another point that was brought up last week. Well, there's 2 points actually, that through state memos. The first is the state acting secretary, Schrader, sent out a memo that discussed providing using 100 of our doses for educators and making that allotment. We have, again, formed partnerships to get well more above 100 educators vaccinated through working with Hopkins and other entities. But since that was taken care of, we worked with our colleagues in Children, Youth, and Families to identify a subset of 100 child care workers to be able to be vaccinated, and they will be vaccinated on tomorrow. And we went to the experts to get their input in terms of who should get that allotment of doses. And so that will roll out tomorrow, and that meets the state's requirement and request that they put forward. It is still unclear whether or not that expectation will roll over to the next week and how that will move forward. The second one was in a memo that was sent out on Monday, I believe, related to independent living facilities. Now, there were a subset of independent living facilities that assumed that they would be covered with a long-term care partnership. If you recall, long-term care facilities are being vaccinated through a federal pharmacy partnership program with CVS and Walgreens and a host of others. And the expectation was for many of those facilities were that they would receive coverage through that. Now, as that process rolled out in the last several weeks, it became clear that there were a handful of facilities that were not included in that. Again, those determinations were not handled at the county level. Those determinations were handled at the state level. And upon finding that out, there has been a scramble to be able to provide support to those facilities. So we received a memo from the state requesting local health departments to put together programs to cover those entities. Now, we have been working with our colleagues in aging and disability to identify those places that were not included within that. And we are working to figure out strategies to make sure that those programs and places get access to the vaccine. Now, let me caution, this will not happen overnight. We're working to get that addressed. And so for those facilities who fell into those categories, I'm sorry that happened to you. We're working as quickly as we can to come up with a strategy to make sure that you, your staff, and your residents receive vaccines in a timely manner. I will stop there, but as always, happy to answer any questions. And I don't know if Dr. Kroll will go next or Dr. Stoddard. The floor is yours.
So I'd like to continue on a little bit with what you were talking about, Dr. Gills, and talk a little bit more about equity, if I can, for the group. I know it's an issue that is on everybody's mind. And to do that, I want to go back to one of the slides that Dr. Gills shared. So if I can share my screen, I don't know where that is in this process. Share screen, here we go. Thank you. So I'm going to put this one up, I think. Share that. So I wanted to go back up to this first. Where is it? Here, this one first. This is the pre-registration statistics through the end of January, showing you the distribution of race and ethnicity of folks who pre-registered for the vaccine. When you look at it in terms of distribution for 75 and over, what you see is some overrepresentation in the white community and some representation in communities of color that does not reflect necessarily the impacts of COVID on those communities. So it's an under-registration, both in terms of real numbers, but also in terms of the impact. One of the things that I wanted to talk about with you, share with you all, is this graphic, which I think was one of you requested last week that I bring to the table today to talk about. This shows the relative over and under representation of census tracts, not necessarily zip codes in the county, in the registration data. The gray is overrepresented in registration, and the red is underrepresented in terms of the share of population for that census tracts. What that tells us is that that communities in the gray are registering more than once or registering multiple times and at a higher rate than the communities in the red. So there's a built-in kind of disparity in terms of the pre-registration that we have to address. And if we're going to ever hope to get to equity. Two other things that Dr. Gills didn't have, but I wanted to share with you, is directly related to equity. When we did our initial equity assessment around this, we identified a number of zip codes that are highlighted in the I'm going to call it fuchsia, I guess, for based on the data that we had at the time that we were using to get ourselves started. And the purple shows, those darker colors, those more purple colors show the COVID cases per 1,000 residents by tract all time. So from day one till now, that shows you where the cases have been. And so you'll see zip codes that we've talked about, 204, 06, et cetera, but then you begin to see where the cases are in this process. We also shifted this look to 90 days. to the last 90 days so that we get a clearer sense of where it's happening in the county and how things are developing in the county. So I wanted to share those with you to give you a sense of why this equity issue is important and why this data is important in terms of describing what is going on. So can I stop the share? Let's stop the share there. Okay. So a couple of things about equity. When we did this piece last week, this first run of this, we looked at, we reserved some of the doses to vaccinate in 1A, to continue our vaccination process for those folks who are in prioritization area 1A. And the remaining first doses of allocation, we allocated to phase 1B, 75 and older, and then targeted zip codes based on the case rates and the death rates that we saw in those areas. And so that gave us a series of zip codes, a top set of zip codes. Recognizing that there were problems with that data, we went back and did some work to clean it up. So this framework now, and this larger way of thinking about equity, does still continue to require that we do some allocation of distribution of doses, allocating some percentage to continue with 1A until that's done, but also some percentage of the doses available have to go now to meet the demands of the state, educators, childcare, independent living facilities, the issues that Dr. Gales was speaking of. What's left then, we can continue to allocate to 75, those persons in 1B who are 75 years or older, who are within high impact zip codes. And those high impact zip codes are determined by overall case and death rates. Those places where those zip codes where they have the highest overall case rates and overall death rates. But we're looking at the last 90 days rather than the lifetime, because things have changed and shifted, and we need to be going where the virus is attacking us. So it gives us we'll be looking at a more recent time window and a shorter time window for allocation. But within that, we're also looking at the death rates, the full death rates over the life of the pandemic, excluding residents who were in nursing homes. And just to let you know, we're doing that not with any bias in mind, but the fact is we're talking about how do we distribute the doses that the county has been given, and nursing homes have been addressed, vaccinations have been addressed through state and federal programs. So we wanted to get a cleaner sense of the data. We're also looking at zip codes for priorities where the combination of case and death rates are high for communities of color, even though the overall rate of the zip code does not reflect it. And that's specifically pointing to that last slide that I showed you, where the zip code may have a very small pocket of infection that we need to identify. Within all of those priority zip codes, we're allocating by race and ethnicity based on the severity of impact. So that'll tell us, it'll guide us where to identifying and allocating doses to people and to communities that have been most adversely impacted. So that's the allocation of the actual doses. The equitable access is not just dependent on the allocation of doses, but also dependent on access to pre-registration and scheduling. So we have to do work. The data is showing that people are not signing up in proportion to their numbers in the population or in relation to the impact of COVID on the community. So we've got some work to do to increase and access to pre-registration and to scheduling when it's time. As part of our equity plan. The second piece is that we need to assure that the prioritization is honored, so that we have to make sure that people are registering when they're supposed to register and signing up to get the vaccine when it's available. And we've been working with the state around the problems we've been having on that front for the last few weeks, and hopefully there's some fixes on the horizon around that. The third point around access and equity is that people have to have access to the vaccination sites when the vaccine becomes available, both by time and location and by mobility. So we have to address those factors and those barriers, the last mile, if you will. And then finally, equity and access does not equate to vaccination or getting vaccine. We have to get people signed up. We have to get them to a point where to address all the barriers. But the other one is that we have to make sure that people know when and where and how and what the vaccine does and doesn't do. and we have to address the hesitancy issues. So if we don't, then we will be looking at disparate outcomes for our communities of color throughout this process. And it is something that we really do want to try to address. So there are a whole series of community work groups that are working on this. We've talked about on Friday, and the work groups continue to do their work, both in terms of Dr. Gales is part of making sure that we have places for vaccine and doses available wherever we can, and that all of that is coordinated. But then the other group to try to make sure we're promoting increased access to registration and scheduling, using phone lines and using outreach to the community, and also doing a broad scale education process for the community to make sure that folks know and what the vaccine can and cannot do, and how important it is to take it, and to deal with their hesitancy. So I think that's a big flyby, a fast flyby, but I wanted to give you the broad strokes of the equity plan and how we see it unfolding going forward. So I'll stop there.
Thank you. Dr. Stoddard?
Good morning. Thank you for having us back. I have a few things I want to add. I'll try and address some questions on a couple different areas that have already been covered. So first off, with regard to the non-public schools, we sent out an alert this morning. What's going to happen with the non-public schools is Hopkins is working with the Association of Independent Schools, which I believe represents 29 of our non-public schools, the Archdiocese of Greater Washington, as well as MANSEF, which is the State Association of Non-Public Special Education Facilities. They'll be working with them directly. For the truly non-affiliated non-public schools, we've actually taken the template for individuals that Hopkins utilizes and sent that out to all the non-public schools. And Emergency Manager will be helping to aggregate those lists together into a single list to send to Hopkins. And frankly, whichever other partners we're able to get to include additional non-public educators moving forward, so that they can participate in, so we can give them the data that they need to be able to enter these individuals into their MyChart system and get them tickets for vaccination times as they become available. A couple of things I know based on questions that we've received. So on the senior front, particularly 75 and older, talking about those seniors, there are two different groups that we're obviously focused a fair bit on, which is seniors who don't have transportation to get to our community clinics. And so we've got a team working on providing transportation working through partnerships like Jessa and others to provide transportation to our community clinics. In addition, there are the true homebound seniors who are, for a variety of reasons, are unable to leave their homes, that we're going to focus on getting vaccinated. I had a conversation with Dr. Kroll last night, and I think we're gonna push this week to try and have a strategy in place to begin to address those seniors. We are collecting that information through the pre-registration process, and that will allow us to begin to put some doses into those arms as well. Obviously, those still fall into our 75 and older priority groups, and so obviously there's not sort of a divergence from that plan. It's just we want to make sure that we have a strategy in place to really address those particular seniors this week. The other thing I wanted to note, I know there were some questions about the data, about how many seniors we've been actually able to vaccinate. So over the last week, we've actually gotten 11,075 and older residents vaccinated in Montgomery County. The total since the beginning is 19,861, according to the data we have from yesterday. Obviously, we've talked about having between 70 and 73,000 75 and older residents. So we're about maybe 25% into that process. At the current rate, let's say we're able to do 11,000 a week, then obviously, and that's not the county doing 11,000, that's the collective, includes nursing homes, includes hospitals, includes all of those settings. It's just residents of Montgomery County who identify as 75 and older. We've gotten to 11, the collective system got to 11,000 last week. And if that's what we see across the entire system moving forward, then we'll probably be in the area of, 4 or 5 weeks covering that group minimally. And then we'll be able to move more reliably into other groups. But obviously, if the vaccine increases or if opportunities increase for 75 and older, that moves faster. And so I think we were asked to sort of give some sense of the timelines for where we're at. The last piece we want to talk about is, I know this has been another area of much emphasis, which is indoor dining. I said yesterday in comments to some of our media partners that we know that we're the outlier in the region in terms of moving forward with indoor dining. I believe the council staff has already been informed this morning that you can expect some action. You'll expect a draft of a potential executive order modification later today, hopefully. We're still finalizing a few of the details. Let me be very clear though, that does not change the fact that in my view, and I certainly believe Dr. Gales and Dr. Kroll agree, that doesn't make indoor dining a safe activity. You will not see us be participating in any of those activities. We're obviously having, we have to make collectively, I know many of you, the council and the executive feel this way, have to make balancing interests between public health and economics and other issues. That doesn't mean, we may move forward with a proposed executive order change that allows for indoor dining this week. And that still doesn't make it an encouraged or safe or, an activity that many people should participate in. And so just because something is permitted does not mean it's a good idea. I think that we would say that moving forward. So you should expect, the council should expect to see something on that later today. Obviously, given your typical timelines, I think, we would think that it would be appropriate for action early next week based on the review process that you all set up. So I think that's all I have that I wanted to add on to, and happy to take questions.
Thank you so much, Dr. Stoddard. Many of my colleagues have questions as usual. I have a lot I'll talk to you about offline, but just a couple quick points at the front. One is I want to remind all my colleagues and the public that we'll have a briefing on nursing homes, which were mentioned in this briefing, next week at this time. We're still hoping to have a representative from the Maryland Department of Health, which regulates nursing homes, but they have not confirmed again. Doctors, I just received an update from folks standing outside line at Richard Montgomery for second shots for the vaccine. Government offices for vaccinations were closed yesterday, of course, but due to the snow. Folks say they were not alerted, understandably, but they're not allowing people to wait in the building, and it's cold out here. They suggest improvements moving forward at that site.
So we'll talk to the team. Obviously, we're on the call right now, but we will figure out a triage. But so let me be very clear. Everyone was notified yesterday about cancellations for yesterday over the weekend. We made that decision actually Saturday morning. Folks were notified that yesterday was canceled.
Terrific.
Thank you, Sean O'Donnell with the team last night at 11:15 when the decision was made to delay until 10, and I discussed with him, and he'd already sent out the messaging that Dr. Gales alluded to, and had reminded those folks who had appointments between 9 and 10 to check the county website for the update, and so there was certainly notice provided.
Sorry, I think I wasn't clear. That was my understanding. The allegation here was that there was not a notification about delayed office government openings today. But anyway, just passing that on because it was immediate. Your slide about the census tracts and the discussion about equity reminded me of something I've been asking. Your slide of the census tracts showed very low pre-registration rates, at least one tract in White Oak. I think others, judging by the map, I would put in Germantown or Gaithersburg. Have we considered, can you talk about what you're doing now to reach residents who don't either have strong internet access or internet skills? And have we considered door-to-door canvassers, bilingual canvassers that could go door-to-door with tablets, the type of outreach that has been successful with the census and probably many of my colleagues' political campaigns? Could you comment on that?
So I could comment, and maybe Dr. Gales may want to join in on this. The first thought about this is that the advantage that the census folks had in going door to door is that we didn't have COVID. And so we didn't have to think about that precaution and those safety issues around this. So that would not be, I would not put it off the table, but I would not put it high on the table for right now until we've gone through, exhausted some other efforts. We are, I think I mentioned on Friday that we are meeting with the group that was the census team to rebrand and refocus them and re-engage them around this COVID issue process. And part of that is to identify ways in which we can reach into communities that have been hard to reach. And some of those that you saw in the census tracts were part of that conversation. I think one of the things we are doing now is identifying places where people can call in. We have a call center, a call line that is a county call line where people can call in and get help in registering, in pre-registering. And we've sent that information out to churches and every place else we can think of to send it out to. But our community, our testing partners in Salud y Bienestar and the African American EC initiative are also sharing that information with folks as they come through the testing sites and in their targeted communities, bilingually and through graphics and et cetera, as part of the communication campaign. We are also having a conversation that we started this week with MCPS to engage students who might need support service hours or public service hours as part of their graduation requirements to serve as call takers, or not call takers, but as callers to reach out to people and help them register. So just some of the early things we're doing around this to make sure we get into those communities.
Thank you so much. And apologies if you've mentioned this, but the state announced at least 2 sites for mass vaccinations. Are you having any discussions with them about one in Montgomery County?
So the sites that they've identified again have been at the state level. There hasn't been any engagement from the state in terms of large scale sites here. We have identified sites, and when those conversations happen, we put forward a couple of those places, for example, like the fairgrounds, as a potential site for that.
Great. You've offered up Montgomery County sites to the state. They haven't accepted yet. The 2 sites they named are Baltimore City and Prince George's, I believe, right?
Right. Well, there's 7, and so I believe it's 7 sites that they've identified across the state. Now, those sites will likely not go live at least for another couple of weeks. I think they're doing a soft launch at Six Flags today or sometime this week. But the expectation is those sites will not go fully live and be fully functional until the week of the 15th.
Great. Thank you. Councilmember Katz.
Thank you very much, Mr. President. I don't know if we're on the 5-minute rule, but I will try my best to live with that.
Let's try that. Thank you for the reminder. And it's
okay. I had a feeling
we were requesting it first.
First off, Dr. Gales, I agree with you in your very beginning when you said that we need to be doing thank yous as well as the jumping up and downs when we have concerns. So I thank you and everybody else, and for all the people who are in the field and working so very hard. And I'm going to try to keep my questions so that there can be shorter answers so that I can get more in for the 5 minutes. But for the people who are over 75, is there a priority because of age? If someone is 80, are they prioritized to get the shot faster than someone who is 75?
So the prioritization that we're using, and I'm going to pivot back to Dr. Kroll, who laid out the criteria. Age is part of that factor, but also looking at a host of other factors, including, where folks live, race and ethnicity, to get a proxy of how disproportionately impacted their particular demographic group has been impacted by COVID-19. And so age is one of those factors, again, along with those other components.
Okay.
And I would just add that not specifically from oldest to youngest. We're not doing a prioritization within a 75 plus age group.
Okay, I didn't think you were, but that was a question I received. In the independent living areas, the Leisure Worlds and the Asbury's and Villages of Rockville, are those the people that are receiving vaccines there? Are they counted in the graphic that you showed earlier? If someone is not signing up through the county website, are they counted in that that graphic? If you know that a clinic is being set up at Asbury, they don't necessarily have to sign up through the county website. So how are the people? That's my point.
Yeah, so I don't oversee the pre-registration process, but if, the number that I'm most interested, obviously we're interested in the pre-registration, but ultimately, if they're not covered in that, they are covered in the number of doses, that are provided, and the state report that they send to us. So when folks are vaccinated, it's the responsibility, at least I know we have the responsibility as the health department, to register that information into the Immunet system. So then the Immunet system sends us a weekly report to say this percentage of this group has been vaccinated. Here's a breakdown of the zip codes. It's the report I believe I share with you all on Wednesdays or Thursdays that gives you a sense of how it's broken down.
Okay.
But also note that we are working on a dashboard that will hopefully be able to illustrate some of these things. That is actually drawing from the Immunet data that Dr. Gales referred to, which is state data. So all of these hospital clinics are sending data up to the state through Immunet, where we're being able to skim that data and be able to report it out and show not just what the county clinics are doing, but what the collective county apparatus involving hospitals, Giants, and everyone else is doing.
And thank you. And thank you for updating about the reason for why public school teachers and educators were receiving the vaccine. And I strongly suggest whenever we send out information, we should send that out time and time again so that people realize what did and didn't happen. On the who should someone contact if they see a business that is not following the people wearing masks and we got concerns about a gym in the county, et cetera? What should someone do? Who should they contact?
They can call 311 to file a complaint, and then that will be fed to the licensing and regulatory services team. That's probably the easiest, cleanest way, and our team will be able to get the complaint and go out and investigate, which is what we've done throughout the pandemic so far.
Thank you. And then the last thing I'm going to mention right now is about the restaurants, and thank you for the update. And I know that we're going to get something in addition about the update for the restaurants. And I guess you said it was going to be 25%. Is that? I saw you on the news last night, or I don't remember whether I heard you today or heard you last night. But if we can, and I've spoken to several people in the industry, if we could continue to send out in the newsletters and everything else, and in some cases we have to repeat over and over again what our criteria is, because people seem to have a tendency to not always remember what was said prior, and so if we can continue to communicate with the industry directly so that they who can follow they want to follow the rules so that they can follow the rules. So I think I would appreciate, all of us would appreciate that as well. Thank you. And thank you, Mr. President.
Thank you, Councilmember Navarro.
Thank you, Mr. President, and thank all of you for everything you continue to do. Again, I will reiterate that this process and this conversation is very difficult given the fact that we have such limited amount of vaccine. So once again, we are trying to do whatever we can to serve our residents and provide that access under extraordinary limitations. Having said that, I have a couple of questions. Childcare providers, there seems to continue to be some confusion. Are we able to provide this information to them via the childcare resource and referral centers, the associations? Are we doing that kind of targeted information? Because again, my office continues to receive questions, and I'm not sure if we're able to use those mechanisms. Are we using them?
So yes. So the first thing is to emphasize is that childcare staff have been grouped in the same, I believe it's in the 1C category with educators, and 1B and 1C. So let me clarify that, because I don't want to get a call be like, teachers, we adhere to the prioritization model. And so they do have access, again, with these outside clinics, as the county apparatus is focusing on 75 and up. Now, we did receive this directive that we had to allocate 100 doses to educators. Given that we had so many linked with our working with Hopkins and others, we decided with some input from some of the state delegations, some of you all on this call chose to use those for childcare staff. And so we reached out to Children, Youth, and Families, who has been a part of all of those networks that you referenced, to get some guidance in terms of who, since we only had 100 doses with that allotment, who to use for that. Now, moving forward, again, one of the things that we're hoping to get clarification about is what that looks like moving forward. And once we can get that level of clarification, certainly the groups that you mentioned will be involved in those conversations about, similarly to how we've had to do with our education staff because we have a shortage of doses, is how would they recommend prioritizing groups within those populations to be able to recommend to move through first and quickly.
Thank you. I will again just emphasize that even just that kind of communication, just for clarity, would be great. Very succinct sort of messaging, so folks just kind of know where they are and what's happening and what to look out for. I think our R&R, et cetera, they're really awesome in terms of maintaining those lists. And again, also through the different associations, as well as whatever other media outlets. I think that just goes a long way, so people at least know, what to expect. The second question I had received, as I'm sure many of my colleagues have, messages from groups that are starting to organize. One in particular is led by Montgomery County Public School teachers and principals, where they are very concerned about the equity impact, and they want to help, especially seniors who don't have access to, to computers, et cetera. They want to help them with the issue of pre-registration, which I think is great, because we can use all the help that we can get. But there's been a lot of confusion about how they can go about doing that. And I wanted to hear from you what you thought would be the most direct way, and also just to understand whether we're, utilizing our aging and disabilities, department division, so that they can also provide some assistance, through all of this. And perhaps that's already happening when you're deputizing the different divisions according to the different groups that we're trying to prioritize. Is there any particular, specific place or number or person that we should direct this group of MCPS teachers and principals?
So, Councilmember Navarro, thank you for the question. I am actually meeting with the group in question tomorrow evening to discuss what they are capable, what they've been doing, and to thank them for what they've been doing, but also to engage them going forward in a more direct way with our work with OCP and the Census Network and the other call efforts I mentioned earlier. So yes, we are aware of them.
Wonderful. That's great. And if you can just, if you can share with my office as well, just so that we're keeping, all of this information in one place. Lastly, I am so cognizant of the fact that we have such limited amount of vaccines. I understand that, but I think that the slides that you have shared, Dr. Kroll, are just so disturbing in terms of how the inequities and the disparities are so stark already. And that really concerns me, because even though we have limited amount, when you look at who has pre-registered, when we look who's gonna then have the access first, we're already seeing this extraordinary gap. And so, we've had this conversation, and I know that we have all these tools, and I'm really grateful for, everything that we are doing. But I do think we need to double down on some of these innovative approaches, especially with our initiatives, but also making sure that we're integrating, every single resource that we have at our power, because I am absolutely blown away by the fact that, I've said to some of my colleagues, it's like watching a dystopian movie play out. And this is very serious. And so, especially given who we are in the county, because these are not small numbers of folks. So we need to figure out how to quickly make sure the folks are being, are pre-registering, that nobody's left behind. The issues of seniors, as we're lucky that we have some senior living, communities, but there are a lot of seniors who are not part of those, don't live there. And this all just exacerbates this issue of equity going forward. So again, I know that you have a plan. I know that we've all shared our thoughts. I just would like to know how we can help all of you boost that, so that we can begin to see a bit of a shift in that data.
I would only, sorry, go ahead, Dr. Kroll.
Go ahead, Dr. Stoddard, please.
I was only going to say the county executive has been incredibly focused on this issue. We've had a number of conversations the last, several days really starting to look at the data. I think that, it was really his direction that has pushed us towards this dashboard, because I think what the dashboard will show us is a couple things. We have inequity. There's no question about it. It may not be quite as bad as other places in the country are, which is, I guess, gives us a better starting point than many. And also, I think one of the big challenges that sort of out of his direction that we've been talking a lot about is understanding better because we're doing a phase-based implementation, and it's not general public. We're trying to understand better what should the exact distribution, given that we're focused on healthcare workers, public safety. We know that there's inequity in those groups already, and so we want to make sure that at a baseline that the inequity, that we're not expanding inequity through the vaccination program and moving it towards a more equitable distribution. And so I think the big question that certainly he's been pushing on is how we better grasp exactly what the breakdown should look like, recognizing that particularly, for example, and I know you know this very well, Councilmember, our Latino population skews much younger in traditionally, and there's a lot of reasons why that is, but because we're not vaccinating into the younger populations yet, except in some of these select areas like healthcare, it may naturally skew our numbers in a way that may lead us to believe that we have a huge problem, when in reality it's just because of the nature of the groups that have been prioritized at the federal, state, and local levels. It creates some inequity in and of itself there. And so I think we're trying to better understand exactly what we should be aiming for and what bar we should be moving. And I think that's a big part of what the county executive's direction to this dashboard has been around.
So
thank you for saying that. Before I lose my train of thought, I think the crux of our equity work is that we have to be mindful of embedding this in every single piece of this execution, because those same, Black and brown folks in these categories also go back to their communities, which has been a lot of the conversation about opening schools, right? That it's not just about, children who are Black and brown going to school because they need it, which they do, but they go back into their communities. And if for some reason they are carriers, then, exacerbates the problem. So I just offer that it is going to be critical for us to embed equity even within the permitted phase in order to arrest some of those, disproportionate issues when folks go back into their community, into their household or whatever, as much as possible.
Councilmember, I think
sorry, Dr. Kroll.
That's okay. You were spot on. I think that we will continue to look at the dashboards and continue to look at the data, but I think the reality is that what we see now tells us that we have got to do more. And so there's a question about, does the data in registration reflect a disparity when you adjust for age? But I'm playing the long game. I'm looking at the long game. We have a whole community of folks that historically have had disparities in healthcare outcomes. And my goal and our intent in this is to make sure that does not get perpetuated in the distribution and vaccines. I can't make someone take a vaccine, but I certainly want to do everything I can to make sure they have every opportunity to do that. And I want to make sure that I have a conversation with them about why they should. So all of that is all of the things you heard me talk about and Dr. Gales and folks talk about is driven by a sense of not wanting to do anything that is going to perpetuate some inequities in this process.
Thank you. And I've gone over my time. Council President, I would like to officially request that we make time in one of our upcoming sessions to just focus on the issue of equity specifically, because I do think that this has a lot of layers that we all need to just understand and figure out how we can work together. Thank you.
No question. Thank you. Councilmember Friedson.
Thank you. First of all, I appreciate Dr. Gale starting with the appreciation for everybody working so hard for a really long time and not realizing how long this was going to be when our first health briefing took place here, and you were doing a lot of work prior to that health briefing, which I believe was either late February or the very beginning, maybe the first day or two of March. We're 11 months from that point, which is hard to imagine. And I was just reflecting on that the other day, that first briefing that we had of how we were preparing, and here we are 11 months later. So thank you for that, and thanks for all of the work that has taken place. I will just note, Acting Secretary Schrader was asked recently where to sign up for the vaccine and couldn't come up with an answer. And without being directly critical of any individual person, that reflects the challenges that we face. And that is certainly not on any of you, and council member staff and executive staff and all of our teams are taking the brunt of the frustration from the community, which is certainly understandable because these are issues of life and death. But there are really significant challenges with the way that this process has been set up, which is completely inadequate and isn't necessarily on the county health department and its ability to fix all of it. But I appreciate you doing what you can to try. I'll continue to push for improvements. I hope that we can work together to make that happen. The independent assisted living question, that's just one of many examples of the challenges with this rollout that are out of the county's control. I appreciate the work that is happening there. Do we have a timeline of when we might expect that to be implemented, or different clinics to be set up? I know some of that is going to be done through hospitals potentially, and not necessarily through the county health department, but do we have any sense of timing or anything that those residents or their family members should be doing in the meantime?
Well, unfortunately, we don't, because there's two challenges. One is the doses that would go to those facilities are being pulled from the same doses. It's all from the same pile. That 5,500, for example, that allotment. We are trying to get further guidance, given that this has been a directive placed with the health departments, if there will be a comparable increase in the doses to be able to accommodate and absorb that. So that is one of the pieces that we're awaiting clarification on. And one of the exercises to the multidisciplinary approach, we're working with our colleagues in the Aging and Disability Unit who have expertise and longstanding relationships with the facilities to come up with some type of prioritization mechanism, again, to be able to move through and start to get folks vaccinated quickly, recognizing the limited supply. So all of this is happening right now. We don't have a definitive date when we'll be able to roll it out. In the meantime, we would encourage folks to continue to advocate at the state level. If they've got concerns, well, not if they have concerns, but to voice those concerns, to hopefully be able to move the pendulum at the state level to increase the amount of doses that we receive so that we can get more people through the queue quicker.
Appreciate that. And just very related to this is the homebound issue. Sorry, Doctor.
Yeah, I just
before you answer, because I know you've been focused on this. I've asked you a lot of questions on it, but related to the homebound issue, if we have timing on that, I appreciate your focus on it, but any timing on that and anything that a homebound resident or their family or caretaker should be doing in the meantime as that effort gets ramped up and ultimately communicated. Dr. Stoddard, sorry.
So obviously we need to know about them. So make sure that they're pre-registered and make sure that they flag in the pre-registration process that they are homebound and cannot leave their home. And so that's the biggest thing. We want to make sure that we have a lot of information through aging and disabilities that we talked about. Ms. Brunetto and her group have provided that, but we obviously just need to make sure that they get pre-registered. So if you're a home health aide and if you have clients, you can pre-register on behalf of them just to make sure that they're covered. So obviously we just need to know about them. We're going to be skimming that this week and working with partners to try and get out to, it's not going to be all the homebound seniors in 1 week. Obviously we know that we have, hundreds and hundreds of those. And so it's going to be a matter of how, as we have vaccine, distributing it out in a reasonable fashion, targeting those homes, bringing vaccine out to them. We're going to likely work through our nonprofit partners. I think I talked about this with Dr. Crowley yesterday, and we're going to reach out to some of those to begin to, identify and get them, get their clinical staffing availability to go out and do home-based vaccinations. But I would say we'd like to play this week.
Yeah. I think that the nonprofit partners is really incredibly helpful and will really go a long way. But ultimately, it comes down to whether or not we have the vaccines to be able to distribute.
Correct.
I totally appreciate it.
I just want to say that's correct, and that's exactly the message. One of the things I said to Dr. Stoddard when we talked about this last night, and I haven't had a chance we have not had a chance to talk with Dr. Gales about this, but it is dose dependent and depending on the allocation,
right?
And not just an issue of the funding availability, but it's also dose and capacity of folks available to do that. So to do that kind of injection. So it's something we will work on.
Dr. Kroll, add to Councilmember Navarro's point, I really appreciate that you're meeting with the Vaccine Hunters group. I think it would be really helpful to bring them into the fold. They desperately want to help. There are a lot of residents who do. There's a lot of skill and talent and community relationships there. So that is really reassuring. I will ask that you send it to all of our offices, since I think all of us have been in touch with them, but echo Councilmember Navarro's points there. Really appreciate that. Last question. Nonprofit partners, many of these are those who are doing work alongside county government. Many of them, at least the frontline workers, are, I believe, in phase 1C, tier 3. But there is some confusion of whether they're supposed to be pre-registering on their own, whether or not the county is going to be pre-registering them through it. I'm thinking of organizations like A Wider Circle and Interfaith Works and many that you know, but could you just explain what is the suggested process for those organizations and their staff?
So for food access providers, we're already collecting those. So obviously there's a contingent of nonprofit providers through that network. We're collecting those. For the other nonprofits who do non-food based work, we have our community organizations active in disasters. I'd be happy to sort of send out some information about exactly the information they should be collecting. But essentially, they should have a list ready to go as we get through the tiers. We'll be reaching out to the various organizations in the various tiers, starting to collect their lists. So as long as they have their list, and the list should really include the prioritization based on exposure risk of their personnel who are front facing and working directly with clients, name, address, and contact, email and or text.
I'm over my time, but if you could send that to all of our offices, sure. Maybe put it up as an FAQ on the website. And I would even suggest all of the organizations that have received community grants to provide that information to them, since we should have all of their contact information. I think it will go a long way to just allowing them to understand how the process is going to work. Thank you, Mr. President.
Thank you, Councilmember Rice.
Thank you very much, Council President, and thank you, Dr. Stoddard, Dr. Gales, Dr. Kroll. This is frustrating, and it's really sad, because just this morning we presented a proclamation honoring a worker who fits into the category of what we're talking about when it comes to a person who could have benefited from having vaccine access. And we know that story is all across this county. And while we know that everybody is at risk, we know that our people of color, especially those with health conditions, continue to be at a higher disparate risk. And so it's frustrating because we keep talking and acknowledging the fact of, yes, it's a problem, but it seems as though our hands are tied. And so I keep wondering when we're going to be honest with our community and just say, look, there's part of this that we have no control over. Dr. Gales, I heard your comments at the beginning, and you're right. Internally, as the Department of HHS, with your doses that you control, you certainly have been working within that equity framework. But the reality is that we have more doses outside of what you have that don't have that same commitment. And who loses are our people of color in our community. We should be frank and honest and real about it. And so I echo Councilmember Navarro's statement about us having a meeting. And I applaud the vaccine hunters for what it is that they're doing, being equity warriors. But the reality is that even with giving them the more information and coordinating with them, the chips are still stacked against them. The chips are stacked against everybody who's a person of color, who's of older age, who has higher risks of any kind of other health conditions. And so let me just be honest with you. I'm talking to, as Councilmember Jawando said, the millions that are watching at home, and just tell you that your government is not able to control this from a local perspective because we don't have the power. The reality is that the power lies with the state. The state has made a choice to privatize vaccine distribution without ensuring that it goes to those who need it the most. Those are the facts. The numbers speak to it. We see it and we see the results. So I don't know why I continue to talk about it, because it's clear that over the weeks that we have talked about this, nothing has happened. no movement, federal, state level, leaving those that are most at risk still at risk. So one of the things that I did want to dispel that I heard is a continued reference to folks who are wary of taking the vaccine in our communities of color. We know they exist. I have them in my own family, but the reality is that there's so many out there who want the vaccine right now, who are ready to show up at a place and roll up their sleeve. So let's stop talking about them and talk about the hundreds of thousands of folks, the millions of folks across this country who are begging to get the vaccine. Let's not let that be a part of our conversation. Let's address that when we get to it. We're far away from that right now. So I apologize, Mr. President. Not a question, just a statement. And saying again that we really have to focus on what is at hand here, which is a complete failure of a system to prioritize those in our community that are most at risk. Thank you.
Thank you. Councilmember Glass.
I'd yield back to Councilmember Rice to continue his very eloquent statement. Thank you, Councilmember Rice, for saying that. Absolutely necessary and absolutely true. And so I also just want to start by thanking all the county staff and the healthcare professionals who are on the front lines working extremely hard. They've been doing this when we started the testing, and they're continuing to do it now that we've expanded to vaccines. So again, a heartfelt appreciation. And I also am appreciative of the presentation that Dr. Kroll provided us. You know, the slides, particularly the map with the zip codes showing the over and underrepresented communities. It's deeply disturbing to see that our communities of color are the hardest, which we know, are the hardest hit communities, that they are also the most underrepresented in our vaccine distribution. And like everybody else, I've been following the news, both locally and nationally. And I know that Montgomery County is not the only jurisdiction experiencing this disparity, but it doesn't make it any less frustrating or upsetting. And quite frankly, it's downright disturbing. And so I, again, associate myself with the comments made by my colleagues about the need to correct these inequities. But I want to pick up on a point that was made, I think, by Dr. Kroll about the census team. And I think Council President also mentioned this. I think it is a great idea to get the census team back together and implement a smart strategy to go directly into the underrepresented communities. It's that type of creative and innovative approach that I hope will ensure that those underserved communities register and get the health care that they deserve. And we know it's a matter of life and death, and that is not hyperbole. That's real life these days. And quite frankly, we have a moral obligation to get this right. And so following through at that point, my question, and I don't know who would be directed to, quite frankly, maybe Dr. Stoddard, how are we using the Office of Community Partnerships and the incredible work that Director Vu and her team do, since we brought up vaccine, we brought up the census and that community outreach component? So
I'll jump in, Dr.
Okay, Dr. Kroll, sure.
So the first thing that we did back at the start of this process, we stood up a community campaign, of a COVID communications campaign work group that involves members of PIOs from all the departments. But very quickly we realized that having, if we were going to reach into the communities of color that we needed to have the boards and the commissions or the work groups that Diane Vu has as part of OCP. So we brought her and her group to the table very quickly. And as we worked on, as we deepened our work, we realized that we needed community partnerships. And at that point, we recognized that we needed the census group back in the mix. And so we pulled in, we again called on Diane Vu to be part of that process with us, so that we have folks who are not only doing communications out around the details of the vaccine and the facts of the vaccines down at the community level and in the community, but also reaching into the community to help folks pre-register, to help folks go the last mile to get to a chair, to help us identify places we should be going and should be targeting, and communities we should be targeting our messages and our support to. That work is kicking off this week in earnest with Diane Vu's group and with regional service center directors and other leadership from other communities, faith-based community included in that mix, to basically lay out for them where we are and what we need and what the challenges are. So some of the things you've seen today will be shared with them. And the request is with groups like Vaccine Hunters is here's how you can be involved now. Here's some things you can do now, and tell us where else you think we need to be going and where we need to be targeting our efforts most acutely. So with across the diaspora, the Amharic, the Caribbean communities, within the Latino communities, and with the Asian communities, where are the issues, where's the hottest need and the greatest need, and how can you help us to get there? So it may come to Councilmember Hucker's point from earlier, that it may come down to going door to door and knocking on the doors. If it takes that, that's where we'll go to do that. We obviously have to be careful about it, but we got to get to the folks that need us the most and help them get registered and scheduled. So
I agree with that. And when we do come back at a certain time for that more focused equity conversation, and I appreciate Councilmember Navarro making that request, folding this into that conversation and learning what those efforts are, even at a more granular level. But the reality is this, for those people who did not see that chart or that map, thank you, Council President. Let me just finish this. The data is this: the pre-registration rates in Montgomery County, 69% of pre-registration are made by white residents, 14% by Asian and Pacific Islanders, 8% by Latino community members, and 6% by Black residents. That is not at all the demographic makeup of Montgomery County, and this is an issue of equity, and we have to get it right. Thank you.
Thank you. Councilmember Reamer.
Thank you so much. Briefly, you mentioned the regulation will be coming over to allow 25% indoor. Could you please just restate the timing on when you expect that to be and when it would likely take effect if approved?
I think you'll have it today. That's, I think, the strategy. I think council staff have already been notified by the county executive's county attorney's office that it'll be coming over today. I think there's some final language that has to be clarified exactly around. As you'll recall, we had the alcohol sales conditions before. We're trying to figure out exactly how that will be stated in the order. You'll have it today. Typically, we've operated on the timeline that you all take, for public review and comment, usually about a week, and so it would take effect. Presuming you are, again, this is up to the approval of the council. If it were to take effect, it would be likely Tuesday when you all act next week. If that's the timeline, I don't know, but that was our thinking given how you all have previously wanted public comment and feedback, and then voted the following week. So
thank you. Just to continue the conversation about our ability to manage the equity framework here, I really trace a lot of this also back to the state's failure to build a rational registration system. And, I don't yet know what was possible, what other states have done, that is a better model. And I intend to look more into that. But if there was a unified database that everybody was essentially pulling from, where then it would be much more possible to achieve what Councilmember Rice is talking about, which is, an equity lens through the private providers. And I do recall Dr. Gales had said that we are providing our pre-registration data, at least on some basis, to some of the hospitals because we have that, pre-registration data. But I am still baffled by the state's, lack of preparation for this event. It echoes the healthcare rollout of many years ago that I would have thought we had learned the lesson from. And I think there's universal frustration about being in this place today. I want to thank everyone for the update on the 75 plus, resident information. I did send in a number of questions about that, and I'm really appreciate the answers that were provided today. I think it underscores why opening up to seniors was necessary and good. A lot of those 1A doses, unfortunately, were going unused. And you saw the state's administration of the distributed dose on a statewide basis was low. The hospital numbers were low. And by opening it up, we've immediately gotten that number up. And now the statewide successful administration number is much higher. I think it is, increased by 50% or something over the past week, enabling us to make a more forceful case, I hope, at the federal level for additional doses. As for some of the specific living facilities that have been mentioned, we've talked about Asbury, Leisure World. There are a number of them, and it's still, I'm not able yet to decipher which ones are going to be covered by the CVS program and which are not. But there are a lot of buildings around the county that have a higher share than others. And I know a lot of it's going to be income based, but of infirm residents, with real mobility challenges and health issues. And, we have to know we have to have a plan for those. And I know you're that's in motion with certain facilities, but I can't tell if it's a comprehensive look. But, if we could get an update about what those facilities are, the HOC buildings, privately owned buildings like Charter House or Victory Tower. There's just a lot of them. And obviously I think there'd just be a benefit for everybody to be able to get into those facilities with a mobile clinic and take care of a large share of older residents all at once, some of them who may not be able to easily make an appointment themselves. I wanted to just note on the mask guidance that we are providing. I think we've talked a little bit about double masking, but some of that, I think there's more knowledge today than there was. I mean, there definitely is, months ago and many months ago. If your view, which I presume it is that, there is a preferred mask arrangement now, especially with the new variant. I've heard a lot of talk about a surgical mask beneath a cloth mask as kind of like the best that a average person can do. If you can, I think we ought to provide more guidance now about double masking, because I think there's just a concern. Like I have seen it said, like always double mask now when you go to the grocery store, or if you do indoor dining, which people hopefully will not linger in indoor dining, but always double mask in these kind of settings. I think that's a good, simple rule that people could follow. And, I think we've had a terrific campaign around masking generally. It might be time, I think it is time to kind of just 2.0 it and clarify there. Also the Super Bowl, it's been so hard to see how much of the wave of cases was driven by people gathering for the holidays. And if they're going to get back and gather again for the Super Bowl, even if it's outdoors, if they're all standing close to one another, yelling and screaming, drinking a beer, that's going to be a problem. The Super Bowl will turn into another super spreader. And we've got to tell people to back off on the Super Bowl. It's the last big gathering moment, of the next month or two. But I am worried about that because it just seems so clear now with the cases coming down, how much of it was driven by the holiday peaks. Last question I'll leave for you. How are we communicating with people when they have an appointment? So if you've pre-registered, you're 75 plus, you get what do you receive? Do you get an email? Do you get an email and a phone call? How long do you have to talk to people who haven't yet gotten an email or a phone call so that they know what to expect?
So in the previous system, you complete the registration online. You get an email confirmation that says your appointment time. This is where you are to go. This is where you will receive your appointment. And you show up, you register there, they check off your name, you're in the system online. Now, one of the strategies that to help alleviate some of the issues that were talked about from a technological standpoint in terms of access, as well as from the whole link sharing issue, the team this week is actually going to pilot calling folks and doing appointments over the phone as opposed to doing it over email. Again, recognizing that a large group of seniors may have more access to phones as opposed to being able to do the registration online themselves.
Good. Glad to hear that.
Well, I will add a little bit to that too. So just in the pre-registration system, you can actually have someone else pre-register. So when that person, that will be the person who receives the email and phone. So for older adults, for example, they may have their children receive the notification, so their children can help them with the actual appointment selection process as well. And so we do have that option in the system already, but you will receive both a text and an email if you fill in the box for both of those. And so that way you can get notified through multiple sources. But as Dr. Gale said, given the way the state's PrepMod system currently functions, we're attempting to do a workaround for that registration system, that reservation system, I should say, to have people directly called so that they can pick a time and all those things right now. And I will add on the independent living facilities. I believe Ms. Burnetta from Aging Disabilities said there are 61 independent living facilities on the call the other day. Some of those will likely have been covered by virtue of their relationship with a nursing home or assisted living. So some of them have an independent living portion and a nursing home portion. And I believe the independent living portions of some of those facilities were covered by virtue of that nursing home partnership within the same building or same space. And so we don't believe it's 61, but it's likely over 50 that we have to address. And the challenge that obviously we have is if we pick 1 to 5 the first week, we've got 45 to 49 facilities the next week saying, why not us? And so when we're trying to make, that's the challenge that we're going to face. And so we're trying to figure out exactly how we make this fair and equitable, recognizing that we can't do 50 facilities one week. We don't have enough vaccine, period, to do 50 facilities one week, even if we had the logistics ready to do it. And so that's the decision that's coming this week is how exactly we integrate those. And frankly, the other side of it is how we understand exactly of that 61, how many have actually been covered through other entities, so we know what the real pool that we have to deal with is. And that's sort of working with the nursing home portion as well as working with the hospitals to know where they've already done clinics. They're doing them right now, just to be clear. There are doing some independent living clinics. I know hospitals are doing them in the larger ones and have been doing them and will continue to do them, but we just got to figure out what the delta is that we may be asked to help with and see whether we can partner with the pharmacies, for example, to have a direct relationship with them to do those facilities. So that's all. The letter came down on, I believe, Sunday into Monday, and so we're working on it this week.
Thank you.
Thank you, Councilmember Jawanda.
Thank you, Mr. President. I feel like I'm in like the twilight zone here. Dr. Stoddard, I know where you stand on this, but I just want to restate. You said I won't be doing indoor dining because I know it's not safe. If I went around and asked everyone on the call, my colleagues, I would hope and I think we would all say we're not doing indoor dining because it's not safe. But you're talking about sending over an EO to open up indoor dining when the CDC says that you're twice as more likely to contract folks that are in an indoor dining setting than folks who aren't. The numbers are going down. That's great, but why would we go backwards with what we're trying to do? Councilman Reamer mentioned the NFL. The NFL has some of the best data in contact tracing because they've spent millions of dollars because of the industry. And in a joint report they put out with the CDC suggested that the closer contact, it actually isn't 15 minutes and 6 feet. You can get it a lot sooner and from further away. So I just don't know why we would send any message, which is what we'd be doing if we approve a 25% indoor dining allowance, that's okay. While we're trying to get teachers vaccinated, 75 plus vaccinated, get kids back in school. So I'm not supporting it. I'll just say right today, I won't support it. and I don't think we should. We should keep the progress we've made. We've got these variants coming that are here. We've got reports in Maryland. Dr. Fauci and others have said that, they're very concerned about these. It just seems totally backwards that we would say we've made a couple weeks of progress and we're going to open indoor dining. So I know we can't control everything. I share all my colleagues' frustration with the governor and the secretary who doesn't know how to sign up for a vaccine and can't direct our folks. We don't have enough vaccinations. We keep asking for more. We need more. We need better coordination. I agree with all of that, but we've got to control with what we can control. It's cold, it's snowing. When we stop indoor dining, it does discourage people from going to indoor dining. They can drive somewhere else, but it's less likely in this context. So I think we've got to keep that going. I guess I would just ask specifically, Dr. Stoddard or Dr. Gales, do you believe that we should be reopening indoor dining? Whoever wants.
Yeah,
both.
I'll start. I'll start. So, and I'm sure I know Dr. Gales. Dr. Gales can add on. I'm sure he will. From a public health perspective, it's not a safe activity. We have realized through this event that there has to be a degree of balancing that we consider the economic impacts as well. It is improving in a public health setting. There are many other jurisdictions around us that are currently allowing indoor dining to operate. I would argue that that's not in their public health interest, nor is it in ours. But from an economic perspective,
I get it. I'm not asking tough choices.
I think that's I'll say from a public health perspective, it's not a safe activity. Any activity where you cannot functionally wear a face covering for a portion of the activities, where you are indoors with other people for, a short amount of time is one thing, extended amount of times, even if we limit it to an hour for dining, for example, you're still at significant exposure risk. I would not, my family won't participate. I would certainly discourage my friends and family from doing it as well. That's sort of the public health perspective on it. Dr. Gales.
I appreciate that. You can add something if you want to, Dr. Gill.
I'll just say this. I'm a public health official and we provide public health guidance. There are certainly risks with the activity. And in the instance, if, there is an effort to move forward, we'll try to provide the best public health guidance to mitigate transmission as much as possible in that setting.
I appreciate that. I know you're not policymakers. I've talked to restaurant owners too. Here's the thing. You have a small restaurant, you open it up, one of your folks gets sick, something happens, you have to let them go, or you bring them in and it's for 2 weeks and then you have to let them go again. The cost of bringing them back in it doesn't even make much economic sense for a lot of people. We should just send the signal to do takeout. And then we should have as much federal and state and local support for restaurant. We have another program we just approved for the state money. We should do more of that. I just think we're in 4 to 5 weeks. You said it's going to take 4 to 5 weeks to get through the 75 plus. If we do 11K a week, unless we get more vaccine, that's right on the timeline where the school system has said they want to open schools. The variants are here. I just think it would be absolutely ridiculous for us to move back and do this and risk another way to exacerbate numbers going up higher, which many people are worried about with variants being exposed. So I just wanted to make that point. The last thing I'll say, I totally agree about the equitable distribution. I hope we're integrating it, Dr. Kroll and others, with the services like food drop off and other things. We should be knocking on doors to get people signed up for vaccinated much more than we should be risking indoor dining. So if we got to choose between those two things, I think that's an easy choice. I really appreciate the opportunity to have the session on other strategies. I'll have more questions about that then. And then Dr. Gales and Dr. Stoddard, I just want to mention, I have two residents that reached out that are 82-year-old residents that don't use the computer very well. We're helping them specifically, but I know they're not alone. They've said they've reached out. They've called Giant and Holy Cross. No one's called them back. They're trying to get an appointment. What do we tell folks like that? I'm going to connect with these folks directly, but for other people out there that are dealing with that exact situation, could you just restate what you should do if you're watching and that's your situation, or you know someone in that situation?
Well, if you know some folks in that situation, for those of us who may have access to computers or a little bit savvy or it comes to computers, reach out to those seniors and try to get them registered as quickly as possible. So if they're in your family network or, your friends network, work to assist them and, coordinate with them to try to get them registered, kind of what you referenced you were doing and helping out a number of folks. And the second thing is it's not finalized, but we are creating similar to when we, back in the day, in order to get a test, you needed a provider referral, and we set up a call line here to be able to do that. We're doing something similar. And so folks will be able to call in and talk with someone, and there will be a dedicated staff who will help them register, through that phone conversation.
I think that's critical. So as soon as we can get that set up, the better. Thank you. Thank you, Mr. President. Thanks for all the work that you all are doing.
Thank you, Council Member. Yes, to your point, Council Member, I know many of you are aware that of course, the governor issued a relief package the day after we held a statewide rally on January 10th. It was mostly a lot of tax cuts. The Senate greatly improved that last week and expanded the grants for small businesses. It's still inadequate. I'm hopeful that the Senate will pass that package, improve upon it on the Senate floor, and I believe the House will be expanding that package when it comes to them after they begin in the next week of February. I think, Councilmember, you're exactly right. The small business owners are collateral damage here, and nobody should be forced into the false choice of reopening in an unsafe environment due to economic pressure or staying closed and losing their investment. The state has over $1.5 billion in surplus and rainy day fund. It is well prepared to throw them a lifeline and get them through the next 6 months to keep those businesses afloat and keep those jobs alive while we get vaccines in arms so that everybody can reopen safely at the right time. Both our U.S. senators have agreed with that call. Yesterday, Congressman Trone came on board as well. So I really hope that our state lawmakers greatly improve upon the plan that came out of the Senate B&T committee last week. Anybody else want to get back in the queue, or are we going to finish this section early? Councilmember Friedson, Councilmember Glass.
Yeah, just very briefly on the restaurant. I understand that this is a very complicated and challenging issue. It seems like we'll be taking it up next week from the timeline. I also just wanted to raise one other and just get a public response to it on youth sports. Now that there's been public conversations about MCPS reopening and what the timeline is for that, some discussions about what youth sports look like there. Now that you're looking at indoor dining and some other areas where we are at least seemingly out of lockstep with some regional counterparts, even if there are significant remaining public health concerns. Just wanted to get a sense if there was any internal discussions or thought of making any changes to youth sports in either in this executive order that we've yet to see or in any subsequent changes to the restrictions.
So as it currently stands, we will continue to follow those same policies of our regional partners as it relates to youth sports and the restrictions that are put into place. At this time, there is no expectation that there will be any language in the EO that will be sent over related to restaurant reopenings related to youth sports. Now that said, I do know that the athletics team from MCPS is looking at how to potentially restart sport athletic activity when schools reopen. We do have representatives from Public Health Services and HHS and other venues who are part of those discussions. I do expect and suspect that when youth sports are ramped back up, that there will be parameters in place, I think, that are a little bit different from the summer and the fall. I think that in order for some activities to resume, there will be requirements or expectations of face coverings to be worn in certain activities, which is different from, some of the parameters that were put into place before.
I appreciate it. I continue to be concerned about, and I know we all are, about social emotional health of kids. And I think youth sports is a key area that kids have an opportunity to do that, particularly in a controlled setting. And I am concerned as we look at these activities of informal gatherings of young people in uncontrolled settings and what that might mean. So I appreciate you continuing to look into that, because I know it's something that is weighing heavily on all of us. I just wanted to get that response. Thank you.
Councilmember Glass.
Thank you, Mr. President. Wanted to focus my first comments on equity, and I just have another question unrelated to the equity component. I've been speaking with a lot of folks in Annapolis about the vaccine distribution, and we here in Montgomery County continue to make the point that we don't view it as equitable. The governor has been saying it's based on per capita, and so based on our 1.1 million residents, we're getting that. But clearly, the need, as we've been discussing throughout this whole conversation, the need is greater than that. And so, in looking at the numbers and the metrics that the state is relying on, it seems to me that the vaccines that are going to our healthcare systems, in particularly those that our hospitals are receiving to vaccinate their staff and personnel, that those numbers are counting towards Montgomery County's overall number. But we know that there's considerable number of medical professionals who do not live in Montgomery County, but they work in Montgomery County. Case in point, Washington, D.C., Montgomery County residents cannot get vaccinated in D.C. even if they work there. And so I'm curious if the number of vaccines specifically to healthcare organizations, hospital systems, the vaccines that are being given to out of county residents are being counted against our general population.
So Councilmember Glass, I actually want to clarify something. So we have had Montgomery County residents get vaccinated in DC to work in DC. So
okay, thank you for that.
You want to clarify that? So yes, so yes, we along with DC and Northern Virginia and a host of other jurisdictions do have these reciprocal understandings that for folks who, even if they don't live in our jurisdictions, if they work here and contribute to our economy and business operations, that we will cover them. So there have been some reports of some situations where county residents have been in hospitals or other places where they may not have received the vaccine, and we're trying to find out more information. But just wanted to clarify, we don't know the exact number, but we do know that we do have residents who've been covered in DC and other areas. Now, so you're right, the numbers that are reported in terms of the doses that are sent to each jurisdiction does include the cumulative doses that were sent to our health systems and hospitals early on. And yes, they did provide vaccination. I don't know the exact percentage, but did provide vaccination for folks who work there, but did live in other jurisdictions. And so they weren't all totally from Montgomery County. Now, based upon the Immunet data that is in place, from my understanding, when they calculate the percentage of residents covered, that is being pulled from, dose was administered to Evan Glass, who lives at zip code X, which is a county zip code, and that's how that information is charted.
And important to note, Evan Glass has not received a vaccine. So your scenario, just want to put that on the record.
It's a hypothetical. It's going to happen soon, hopefully.
Okay, because I have heard from residents who do work in DC that they have been turned away. Clearly, you're saying that some have. And so, again, trying to level set and understand what the rules of engagement are.
And if there are specific situations, we'd love to have that information because, we talk with all the health officers back and forth, and it would be helpful to know in what settings and situations that those types of things have happened.
Okay. I'll just close by saying that if some of this is a little murky, right, and we're not quite sure where all of the lines of distinction are drawn, I think it is another point to raise to the governor, because again, if they're using high-level numbers to verify what we've been given, but not all of that has been given to Montgomery County residents, I think that is another case to make for why we deserve more vaccines. Thank you.
Very good. Councilmember Reamer.
Thank you. Just wanted to note on a positive note, 137 new cases today, if I did the math correct. That is quite a difference. You know, it was terrifying watching our case numbers, 4 or 5. We may have even had a 600 day or two. So, you know, I hope that this will be sustained and isn't some aberration of testing, you know, some backlog that, anyway. And I want to note, as vaccines are administered, our concept of how to measure the impact of the disease, I imagine, will change. I know, Dr. Gales, you would talk to one point about, you know, what the risk is to the community of a given level of spread when more vulnerable people have been able to get vaccinated. So, you know, I mean, I'd welcome your comments here, but I know that there's seemingly a shift to hospitalizations and death rates as being, you know, more of a focus. But can you talk to us about the outlook over the coming weeks and months?
Well, I mean, a large part of it will be dependent upon, you know, the significance of the penetration of these variant strains within our community pockets, you know, given that they are more contagious and can spread quicker and more easily. And so I think that will be a determining factor. So certainly we are encouraged by the numbers moving in a different direction. I respond very differently to 137 than I do 600. But to tell you the truth, I would respond a whole lot better when we're looking at 15 or 20 cases a day and even smaller than 137, which is, again, where we weren't that far off from that, you know, back in the summer. Now, so I think that's going to be the big determining factor. And to tie it into, you know, looking at getting vulnerable folks covered. So obviously we want to get everybody covered to cut down on cases, but it's important to get those who are most vulnerable, because those vulnerable folks are more likely to have a severe form of the disease, which results in hospitalization and unfortunately in many cases results in death. And so the more of those folks we can get covered more quickly and easily, then that gives us the chance to say, even in a setting where we might see an uptick in cases, it's not the same of, you know, if we see an uptick in cases, we can rest a little bit easier because those who are most vulnerable and likely to have complicated courses would be covered. And even in the small percentage that they would contract COVID-19, the severity of their symptoms would be significantly improved.
Thank you.
Okay. I think that wraps up the questions from my colleagues. So thank you all so much for all your hard work and all your clarifications. We're really grateful, as are all of our residents. And we'll see you again soon.